dislocate the lens, and I have seen enough of that. And if you're trying to do it in multiple shots, you'll just be chipping away at the superficial iris and creating more debris, and it will create much, much more problems. The sight, yeah, we usually have a panel so you can go a little mid-peripheral and not necessarily to go right at the edge. And there are a number of papers who say you can do it anywhere in the 360 degrees, but I have seen enough patients refer to me that if it is done in the mid-peripheral region, that is in the interpalpebral aperture area, please be very, very careful. If you have even one patient like that, and they'll keep saying, oh, what you did, I was completely normal. You have put something over.
How I like to close. Both of these implants, they basically, the inherent resistance within the implant because of the lumen prevents hypotony. And then, yeah, so that's the way. And then you're going to see as I tighten this, you're going to get that tight anterior tension. That's what I like to see on all my implants, be it tubes, be it trabs, or be it these implants. I like to see that tight thing. This is company data out of the Dominican Republic demonstrating. And again, let's not look too much beyond 1 year. If you look at the follow-up time after 1 year, I don't know if you can see my pointer. But the number of patients falls out pretty dramatically after 1 year. So, but if you look at the 1 year, there's about a 36% IOP reduction, and the patients are on average 0.5 medications, and they go from mid-20s or mid to low 20s, 23 down to about 14. And this slide kind of demonstrates that the higher dose of mitomycin C, the better the outcomes, and the less likely the patient is going to be on drops. In Canada, Ike Ahmed is doing a lot of these, and he's actually he's injecting mitomycin C, and he's really pushing the limit as far as how much mitomycin C he's using. He's using 150 to 200 micrograms of mitomycin C. It's a huge, huge dose that he's been found to be pretty safe and effective. So I think this is an exciting thing that's coming down the line to help us further standardize surgery. So let's talk about Xen. So fortunately, I wasn't able to do a Xen this time. It's not approved yet in India, but I think hopefully next time I come, we'll be able to arrange that. But the Xen, this is the injector. It's a 6 millimeter long, 45 micron lumen. It's a cross-linked with glutaraldehyde, which is supposed to allow it to last longer. You can perform it through two paracenteses, a 1.8 paracentesis, and then just about a 1 millimeter paracentesis. I inject preoperatively in the target quadrant with mitomycin C. You don't have to take down the conjunctiva. It's really the only FDA-approved MIGS device that creates a new space, creates a new drainage system. And this is a gonio view of what the implant looks like that I took just at the slit lamp. So what does it look like? It's small. It's ideally, this is the company picture, but I don't think it should go through Schlemm's canal. I think it needs to be anterior to that. You go through Schlemm's canal, you're going to get blood reflux. So that's not where I place them, ideally. Some of these videos you will, but you try to go a little bit through anterior to Schlemm's as the target. There are 3 lumens with this implant, 140, 60, or 65 and 45. The company's I was involved with all the trials with different lumen size. The larger the lumen size, the higher risk of hypotony. This lower one is the 140 micron lumen, and then the upper one is what's approved in the U.S., the 45. The 63 is what it is. Hopefully that will be approved soon, because I think that may work a little bit better. As with all these surgeries, the key is not kind of what's going on in the key is not what's going on underneath the screen. The key is what's going on let me just do this one. Sorry. That doesn't work. Let's go over here. All right. The key is what's going on, and this is on my YouTube channel too, so you guys can watch the videos. But the key is, so you make your side port incision. The implant goes in the superior nasal quadrant. So this is a left eye. So I'm doing a supratemporal paracentesis, putting in GV, and then your main wound, the 1.8 millimeter wound, goes through the inferior temporal quadrant, 1 millimeter anterior to the limbus. So it's more anterior than your phaco wound. So it makes it a little challenging to find it because we're not used to finding it when it's that anterior. And that hook allows you to see it a little better. That I always look on gonioscopy about the target quadrant, and then the company says 3 millimeters. I actually did 2 millimeters, so I'm going to cheat a little bit and kind of cause my anterior limbus marker to be a little more anterior. So, but I'd say 2 millimeters is where you should measure. I do about 3 marks. That's where I know I want to come out, right at the posterior ink mark. And then a little shimmy goes through that corneal wound, so you know where you're going. But what the key thing is what's going on in this top left window that I'm going to put in. So, you know, as you're injecting it, watch what my hands are doing in that top left window. You want to gently go through and come out and tent up the conj just a little bit and come out in the subconjunctival space. And so I'm just shimming it, and you can see the needle coming out right there. And then you're going to see my thumb slide the injector anterior. Halfway as in the slide, you're going to see the implant be deployed, and then the other half is when the needle retracts. So I've come out of the eye, I let it come back into its normal position, and then I continue with the sliding mechanism, which then retracts the needle out of the eye. If you have any traction on the eye or torque on the eye, the minute you disengage the needle from the wall of the eye, you're going to get a flick and you're going to cause damage. So that's the most important thing, is all these angle surgeries, not just what's going on in these videos, but what's going on with the hands and everything. And then you want to confirm implantation. You want 1 millimeter in the anterior chamber, 2 millimeters in the scleral space, that's the implant, and then 3 millimeters in the subconj space. And you will see a bleb, and then you want to make sure that it's straight and that you like it, and you like the positioning of it. And then I'm just washing out the Helon GV, and then you'll see a bleb form, a low bleb form. And I do this under topical anesthesia. This patient was blocked, but I now do it under topical anesthesia. And you can see the nice bleb that forms. So well, let's get back to the video. I don't know why that didn't show. So. All right. And that's the... I'm sorry? Yeah, exactly. So this is the classic bleb that you see. I mean, bleb morphology is bleb morphology. This is the dream bleb morphology, but you'll see variations of it. But you see that low diffuse bleb, and you can see the implant right here. So this was we recently published the pivotal trial in the U.S. in the AJO, and I was lucky enough to be the lead author on the study. And what it showed was that this was a single-armed. Again, they didn't go head-to-head against trabeculectomy. They just wanted a single-arm, non-randomized, of 65 eyes of 65 patients at 12 months. You know, there was about a 75.4% of patients had a greater than 20% reduction in medications on the same or fewer meds. A mean decrease in 9 millimeters of mercury, and they went from about 3.5 to 1.7 meds. No really significant or unexpected complications. And so, the gel stent, the conclusions were that it lowered pressure, decreased medication dependence, without any unforeseen complications. The way this was done in the trial in the FDA was we actually had to take down the conjunctiva, put the implant in and then close the conjunctiva, because the FDA would not allow us to apply mito with an ab interno procedure. So it's different than how it's used in the real world. So the data is going to, even this is in the most advanced patients, but I think the data will be better in post-approval when we're finally doing it the way we want to do it. The ideal first patient, the injector is a little cumbersome. So if you're right-handed, then do a right eye first. If you're left-handed, do your left eye first. But you have to get comfortable with both hands. And you really depend on the anatomy. If the patient has a prominent cheekbone, you can't get the injector there. So the first couple cases, it would be great with a prominent eye and a low cheekbone. A nice open angle. I would say do this in a pseudophakic. Block the patient for the first time. And when do I use Xen? I do it in patients that have failed angle surgery, patients that can't follow up easily or are on blood thinners, the patients that have advanced glaucoma, those patients I showed yesterday that don't have a collector channel system and that I know they're advanced and they're just scarred and they need a new drain. These patients can go back to their physical activity literally within 5 days, a week. Because there's limited outflow. And if you're doing this with a toric lens or you need a predictable refractive outcomes, you can do this. When won't I use it? patients with extensive PAS, active inflammation, neovascular glaucoma, angle closure with an unstable lens, patients who will likely need a corneal transplant or a PK, and a really sunken eye and a prominent cheekbone makes it very hard. So I think that, this is a great step between failed angle surgery and trabeculectomy. Again, we're looking for further barriers to prevent me from ever having to create a bleb and make a trab that looks like that. You still create a bleb, and about 30% of my patients are being needled at the slit lamp. It takes about, the learning curve, again, nothing is easy, otherwise everybody would be doing it. But there's a learning curve, 5 or 10 cases, and you get the hang of it. This is still glaucoma surgery. This is not an eye stent. This is not mild stuff. This is still glaucoma surgery. You're still creating a bleb, and if the word bleb scares you, you shouldn't do this surgery. So, this is a tremendous addition. Both of these surgeries are a tremendous addition to our surgical armamentarium. These are going to be predictable and safe ways of creating a new drain. And the Xen implant, when you're seeing it, it's not as easy as it looks. But with experience and training, it can be done safely. And I think when InFocus becomes approved in the U.S., it's going to be a tremendous addition, again, to our surgical armamentarium. It's been really an honor to be here. Again, thank you guys so much for having me. And my email address is on here. If ever you guys are in the States and in Dallas and want to come hang out in my operating room, you're welcome to come watch and see kind of how we do things. But then also, if you have any questions, please don't hesitate to email me. Thank you again for having me.
Thanks, Davinder. Before you come down, there is a question for you. Maybe you can take it. Is it good idea to place InFocus device in suprachoroidal space for better results?
The InFocus device in the suprachoroidal space? It's never been done, as far as I know, on purpose. The suprachoroidal space is this unknown zone. We don't understand it. We don't understand, scar tissue formation in the suprachoroidal space. With SiPass and then Glaukos is coming out with the suprachoroidal shunt, I think if you're looking to make some type of suprachoroidal implant, I would recommend going down that path. But even with those, you get a mild lowering in pressure. And what I would caution in small eyes or in eyes where there's thick sclera, if you're doing a SiPass or a suprachoroidal shunt, you're going to get suprachoroidal fluid, persistent suprachoroidal fluid. I don't do a SiPass or suprachoroidal shunts in small eyes because you get a myopic shift, you get rotation of the ciliary body, and it can be persistent. So I had a patient that was a +4 in both eyes. I did a phaco SiPass in her one eye, and she ended up being a -3. So for a month, and she couldn't wear a contact lens. So she was a little crazy to begin with anyway, but this made her more crazy for a month of -3 and a +4. So that taught me a lot about when these suprachoroidal shunts will be done. But I don't think any of these, I don't think a SiPass, I don't think an InFocus would go well in the suprachoroidal space because it's so small, it'll scar up right away. The lumen of the SiPass is pretty large because the suprachoroidal space scars so much. Okay. Thank you guys.